Welcome to EMClasses Board Review. This is our first episode, and today we're going to be talking about tumor lysis syndrome. So, the big thing to remember is that hematology oncology is not a huge percentage of your ABEM qualifying exam, but tumor lysis syndrome and the other hematological emergencies are pretty high yield on the board review and can be very, very easy points. So, the better you understand it, the better it is. So, we're going to start off with a case. And this is basically a 65-year-old male with nausea, vomiting, muscle aches, hallucinations, and a decreased urine output. He was diagnosed with ALL and started chemotherapy 3 days prior. So the types of questions they might ask for this is, what's the diagnosis? What type of electrolyte abnormalities might you find? Or what are the treatments? Now, what I want you to understand when I give you these vignettes is, let's pull out the important information. If you eliminate all the rest of the words, what are the words that actually matter? So, nausea, vomiting, muscle aches, hallucinations, kind of vague symptoms, don't really know how to put it together. This patient does have a history of ALL, which is a blood-borne cancer, and started chemotherapy 3 days prior. Now, these are all symptoms that kind of point towards one diagnosis, and that would be your tumor lysis syndrome. Now, tumor lysis syndrome basically is a complication of massive cytolysis and the release of all the intracellular products and what happens when they break down. So these patients present with these vague symptoms, but also have significant electrolyte abnormalities and metabolic abnormalities. So it's very important to catch because it can be lethal if not caught. That's why a lot of these patients, who are either adults or pediatrics, end up being monitored after they start their induction chemotherapy. Again, I want to reiterate that these patients often present with vague symptoms, myalgias, nausea, and vomiting. And think about how many times you see these patients in your emergency department and dismiss them with a viral illness and send them home. Now, the renal failure may not be very evident at first. It may be mild and then progress to something much, much worse. But a very adequate history is important. Do you have a history of cancer? Have you recently started chemotherapy? These are all questions that you want to make sure that you ask. So the diagnostic process is not extremely difficult. Most of your answers are going to be found in your blood work. Now you might want to do further imaging, chest x-ray, CT scans if necessary to rule out other things if they're presenting with other symptoms, but in general, you will find most of your answers in your labs. Now, what do we find? What are our metabolic abnormalities? In a nutshell, we're going to have hyperuricemia, hyperphosphatemia, hypocalcemia, and hyperkalemia. Now, that's going to be very, very important to understand and remember for your board exam. Now, what's the process? How does this happen? So basically, you have this blood-borne cancer. Again, very rarely is it related to a solid tumor. And you initiate chemotherapy. When you initiate the chemotherapy, that leads to cell breakdown. And it's that massive breakdown and release of intracellular products that causes your downstream effects. So let's look at it from a DNA standpoint. Your DNA gets broken down. It leads to hyperuricemia. Your hyperuricemia, your uric acid ends up crystallizing in your kidneys, and that leads to renal failure. Secondarily, you have protein breakdown. Your protein breakdown leads to hyperphosphatemia, and that hyperphosphatemia leads to hypocalcemia. Finally, you get cytosol breakdown, which leads to hyperkalemia, because remember, the intracellular levels of potassium are much higher than the extracellular levels. So your hyperkalemia coupled with hypocalcemia makes your heart more prone to dysrhythmias. So that's something that you want to keep in mind when you're treating these patients. So let's move on to the management. So management is going to be very, very heavily weighted towards giving fluids, aggressive hydration, 2 to 3 liters a day, and you want to make sure that you maintain your urine output at 2 mLs per kilogram per hour. Now remember, 2 to 3 liters per day does not seem like a significant amount when you're treating sepsis and volume depleted patients in the emergency department, but for a well hydrated patient, it may not be a big deal. Or it is a lot of fluids, as well as patients who may have renal failure already. The other treatment, and this is kind of alluded to earlier, is you want to make sure that you treat your hyperkalemia and hypocalcemia. So these patients may need your typical hyperkalemia cocktail, which includes insulin, calcium, dextrose. If their renal function is good and they can pee out their potassium, some Lasix may be beneficial as well. Now, these patients may end up needing dialysis if they do not turn around quickly. Some medications that are very, very important to remember are going to be your allopurinol and rasburicase. Let's start off with allopurinol. This basically blocks your enzyme xanthine oxidase, and it prevents the further production of uric acid. Not really helpful when you already have uric acid deposited, but it may be helpful from forming more uric acid and preventing further crystallization in your kidneys. Now, rasburicase, this is going to be the medication that has actually been pretty helpful in preventing complete renal failure and the need for hemodialysis. It's been studied pretty well in kids, not so much in adults, but it has been shown to drastically reduce your serum uric acid levels to almost normal levels within 48 hours. So again, allopurinol and rasburicase are going to be important. If your board asks you, if your questions ask you which medication should you give, usually rasburicase is going to be your better answer. And finally, remember that hemodialysis is an option if your renal failure does not improve and you continue to have metabolic abnormalities and your patient starts to decline. So finally, it's going to be your disposition, and the disposition is going to be to a monitored bed, pretty highly monitored bed. So sometimes the ICU is necessary, sometimes a step-down unit may be adequate, but usually the ICU is going to be the place to go. So I want to finish off with just quick board review pearls, 3 things that you need to know. Remember that the only thing that's going to be low is going to be your calcium, hypocalcemia, and everything else is going to be high. Hyperuricemia, hyperkalemia, and hyperphosphatemia. Now, these things were kind of confusing for me to remember until I remember that, there's only one thing that's low, and it's calcium. So just try to get it straight in your head. I don't have a mnemonic or anything for you. Now, finally, it's going to be your treatment. What is your treatment? It's going to be fluids, allopurinol, rasburicase, and dialysis if needed. Fluids first, rasburicase second, dialysis last. Thank you for listening to this episode of EMClasses Board Review. I hope you found it helpful, and we'll have more videos posted soon. Thank you so much.